finishing up with differential diagnosis. So patients presenting with any major depressive episodes might meet criteria for MDD, or they might meet criteria for bipolar disorder. So again, really important to screen for bipolar disorder in anyone who presents with depression. Anger irritability, that might be consistent with bipolar disorder, but it can also be consistent with the anger subtype of MDD. It can also be consistent with intermittent explosive disorder, and it can also be consistent with things like cluster B personality disorders, including borderline personality disorder and antisocial personality disorder. Mood swings, they also may indicate bipolar disorder, or they can indicate cluster B personality disorders. Distractibility may suggest ADHD versus bipolar disorder, and patients with mood symptoms and psychotic symptoms may have a primary psychotic disorder. So always be on the lookout and keep a broad differential whenever you're seeing a patient. As far as the diagnostic approach to evaluation, so a single episode of mania is diagnostic. So that, is a little bit of a challenge, I think, when you start thinking about bipolar disorder, because, one episode that may or may not meet criteria, it depends on who's doing the evaluation, depends on how they're defining things. So it's really important that you follow DSM criteria and make sure that this person truly is having and meeting criteria for bipolar disorder. And of course, a thorough history and a good review of systems is an essential part of being able to make the appropriate diagnosis. Most patients present in the depressed state, so always screen every patient with depression for bipolar disorder, and hypomania must be distinguished from normal levels of activity. So you need to determine, a lot of people with hypomania, they actually function really, really well, if not better than a lot of other people, because they have so much additional energy. They actually do really, really well at their jobs, they tend to be very successful, and it usually doesn't bring them to the hospital. Again, these tend to be more subclinical presentations, although it can, it depends on the circumstances, but for the most part, be careful in how you define these things. Mania secondary to medical or substance use must be ruled out as well, especially if the episodes occur later in life. So I had a case recently where a 60-year-old gentleman, high-functioning gentleman, working as a dentist, came in and was having supposedly his first manic episode. That alone makes me question things. This person's 60 years old, they were working in a high-functioning professional career, and now all of a sudden they're having a manic episode and they're in the hospital and they're committed under involuntary status. So that in and of itself makes me kind of think, is this really primary bipolar disorder, or do I have to be thinking about substances? Do I have to be thinking about another possible medical condition or organic cause, such as a brain tumor or anything along those lines? But, substances and again, neurological disorders, things like brain tumors, etc., are things you might want to think about if someone is presenting with new onset mania at an older age. So I think that's a kind of a good thing to always keep in mind, and UDS, of course, will help you with that. So what does the management look like for patients with bipolar disorder, especially acute mania? So acute mania is treated with mood stabilizers. Those mood stabilizers generally include lithium or atypical antipsychotics. So remember that the two basic gold standards for mood stabilization would be 1 lithium and 1A would be Depakote. I feel like lithium Depakote, and Depakote, if you don't know, is valproic acid. Those medications tend to be the best two choices for mood stabilization with bipolar patients. So those are definitely good choices if you're going to be making them. Severe cases, you may need to use some combination of these medications, so a mood stabilizer and an antipsychotic, depending on if they have psychotic features, or maybe even ECT or electroconvulsive therapy may be indicated in certain cases. For the acute depressive episodes, they may be more severe, and they can actually be refractory to typical treatment, whereas usually unipolar depressive episodes are more responsive to treatment. So some of the common treatments include mood stabilizing agents and mood stabilizing antipsychotics that are approved for bipolar depression. So there's a list of those you can look up. Some examples would probably be Latuda, Seroquel is approved for, Seroquel-quetiapine is approved for bipolar depression as well. The mainstays in maintenance therapy are lithium, of course. Lithium is a great choice. You should always check renal function, check thyroid function before initiating lithium. Make sure that the patient is healthy in those two areas, and they should get blood work every 6 months or so, just to make sure everything's good. And obviously, it's important to check a lithium level and make sure they're in a therapeutic range because it has a narrow therapeutic window. So you have to be careful with the levels as well. Also, you can use atypical antipsychotics, like I said, and most of the atypical antipsychotics are fairly reasonable choices to go with in the event you can't use a mood stabilizer for some reason. Behavioral therapy obviously is a big one, and also family therapy, because involving the family early on, especially if that is a primary role or primary support system for the patient, you want to make sure the family is aware of what's going on and that they understand the disorder. They understand bipolar disorder. They understand what the prognosis is. They understand what the treatment is. And they really can help the patient moving forward. And it also will help to educate them about what to look out for and what to be aware of while dealing with a family member with this disorder.